Emma. I am a third-year medical student. I'm finishing the end of my third year now, so I'm a soon-to-be fourth year. I go to school at Burrell College of Osteopathic Medicine in Las Cruces, New Mexico. It's about a stone's throw away from El Paso, Texas, which may be more familiar to you guys. But today we are talking about CNS infections. So this is a little bit of sort of a broad topic. We're talking a little bit about neurology. We're talking a little bit about microbiology. We're talking a little bit about internal medicine. So there's really a lot going on in this lecture, as always. It seems to be the case that I pick difficult topics. But as kind of always, for those of you of whom are familiar with the way that I like to lead these, I'm going to try to make it as simple as possible for you guys and really take it down to a pre-med level, okay? And if something's not at the level that you're at right now, feel free to ask any questions. As always, I'm happy to answer any questions at all. Don't be like me as a pre-med student and feel like you didn't want to ask a question because you were afraid of appearing dumb to your colleagues. That's not the case here. I really want to cultivate a very supportive learning environment here. So with that being said, let's get started. All right, so as always, I have a recommended read for you all. This one is actually a shorter read. So it's on a site of which I'm very fond of myself. I've submitted a couple things here also, so maybe I'm a little bit biased, but this is a very good read. I read it a few days before making this presentation for you all, and it's a good kind of recount about sort of your passion in medicine. And for those of you that are applying now or are yet to apply, I think this is a good read for you guys. So here's the link for that. I just put that in the chat for you all to click on. Otherwise, if you want to type it in from the presentation, or if you have access to the slides, you could always click on that link as well. But as I kind of indicated to you before, we're talking today about CNS infections. There's lots of CNS infections in the way of, you know, meningitis, encephalitis, brain abscesses, lots of different things. So it's a pretty, there's a sort of wide breadth of knowledge that you can get from this, hopefully. That's my goal for you all. But as I kind of usually do with you, let me share the poll with you real quick. So take a few seconds to give me your honest opinion about what you know about CNS infections. So it looks like almost everybody is in. I'll give a few more seconds. All right, so let me share this with you guys before we go on. So one person said they know a lot, and that wasn't me. So whoever that is, surrender yourself now and just present the presentation for me. All right, but the most of you guys said that you know a little, and that's usually what I expect from you guys. I expect most of you to kind of be in that I know nothing or I know a little category, and that's okay. So we'll really work on really enhancing your knowledge in order to kind of increase you know, your poll at the end of this presentation. Okay, so let me stop sharing that with you, and let's get going. Also, I hope you guys laughed at this this meme as much as I did. I put it on there. I like laughed out loud. I really like this one. All right, so as always, we're going to kind of follow the same session outline. If this is your first time with us, that's totally okay too. But we're going to kind of go through CNS infections. We're going to talk through a case. There's lots of videos today, lots of things to follow along with, lots of active learning. So I want you guys, as always, to participate. I'm going to ask you lots of questions. Be sure to type it in the chat. I think that that's the best way to learn in the most interactive way that we can do this over a Zoom session. So then we'll kind of go through the physical exam, we'll talk about the assessment and plan, and then we'll kind of talk about the lesson on the pathology of the disease. And then hopefully at the end, you guys can certainly take something away from this presentation. Even the student of whom said they know a lot about it, hopefully they can learn something as well. All right, so there is a SOAP note form to fill out. As a reminder, that's subjective, objective, and then plan. And I'm going to give you all of that information. It should be abundantly clear what to fill in there. And if you are unsure, ask. We can always kind of run through it and discuss it as well, okay? And then at the end, there is a quiz. I did create the quiz myself. I think it's fair for your level. And after having watched this presentation, I hope that for those of you that have tuned into some of my sessions before, that they're fair questions and you're able to answer it, you know, just based off of the presentation alone. That's my goal for you. I don't want it to be super hard on top of everything else you guys are doing. Okay. So let's get going here. So here's the SOAP note form, just to refer to again. The subjective part is the HPI and the ROS. That's the stuff that the patient tells us. Objective is things like the vital signs and physical exams, things that we produce. Then we're going to talk about the assessment, which is our part of our differential diagnoses. And then we're going to talk about what we're going to do, the plan, in order to address those differential diagnoses or the differential or the diagnosis of which we're kind of honing in on. Is a 31-year-old female who's presenting to the ED with a 3-day history of malaise, which means kind of fatigue, like overwhelming fatigue, fever and myalgias, which means body aches. She notes that she typically is very active and is a marathon runner of whom runs approximately 6 to 7 miles daily. Over the last 2 days, she has been unable to get out of the bed due to diffuse body aches, joint pain, and progressing neck stiffness. Her roommate is present and drove her to the ED and claims that the patient has been acting strange, placing her cell phone and keys in the refrigerator. The patient describes a throbbing and unrelenting headache, not improved with over-the-counter NSAIDs or Tylenol. She denies previous episodes in the past and also denies nausea, vomiting, diarrhea, seizures, numbness, or tingling. So kind of get a good picture of the patient in your head now, because I have a few questions for you all. And these are the questions that we want to consider at this point. So number one, what differential diagnoses are we trying to consider at this point? So think broadly. We want to kind of start broad and then focus in on, based on the evidence that we have. So if you have a broad differential diagnosis, that's perfectly okay. So go ahead and throw them in the chat. What do you guys think? What should we be thinking about at this point based on what the patient has? Trish, viral, perfect. Yeah, I mean, this could certainly be something viral. What are you thinking in terms of the viral infection? What kind of infection? Somebody said meningitis. Good. Yeah. Herpes, infectious. Good. Anybody else? You guys can think broad. If you see this kind of constellation of symptoms, what do we want to consider? Or what do we want to put in our differential diagnosis to rule in or rule out? Rabies. Someone's thinking very broad. Good. Head injuries, yeah, you can absolutely consider that, especially given her headaches. Good. So let's hone in on the food poisoning. Yeah, absolutely. So since she has the body aches and stuff, she doesn't have any nausea or vomiting, but we can certainly put that in our differential. So what about the headache and the body aches? What do we want to kind of hone in on with those things? Or what do we want to rule out with a headache? Psychological, certainly, yeah. Exercise, yeah, we can consider exercise. Yeah, trauma, good. Great job. What else? Brain injury, good. Migraines, perfect. You guys are right on the path. What else? What serious things do we want to consider when we think of headaches? They may be kind of to one end of the spectrum. Obviously, migraines are one of the most common causes. Cancer, yeah, we can certainly think of a brain tumor, good. Concussion, yeah, these are all things we want to consider. Hematoma, perfect. Yeah, I was just going to say we want to consider brain bleeding. What about with her neck stiffness? What do we want to consider with that? Hope, good. Hemorrhage, exactly. We want to think about maybe a subdural hematoma. I know one of my colleagues had taught about brain bleeds earlier in the sessions. Spinal cord injuries, sure, we can certainly consider all of those things. Good. All right, so our next question, why ask the patient about what they do on a daily basis? Why is this important to ask about their social history or what the patient does? This may seem like a trick question. It's absolutely not. To see if daily activities contribute to the pain? Sure, exactly. Yeah, exactly. And the other reason why we want to ask about what they do on a daily basis is to see how their activity is affected. If somebody's a couch potato, you might not be able to see how they're affected, depending on, if they're a marathon runner and they usually run 6 miles a day and now they're not even able to get up and walk. That's a pretty good indication to us that something is going on. You guys are all on the right path. Good job. And then what questions should we ask before we go on and before we put our orders into the computer? What else should we consider? Good. We can consider her age. Yeah, we know her age is 33, and we know it's been going on for 3 days. So we know those things already. Meds, yeah, good. If she takes any medications, any family history, good. Yeah. Family history of anything. Yeah, you guys are right on the path. Great job. And I think I have one more question for you. What do we want to examine on this patient? What do we want to take a look at and hone in on in terms of the examination itself? The neck, brain. Good. Yeah, perfect. Specifically the neck. Yeah, I like that. Vision, absolutely. Head and neck. You guys are right on the path. But because we're thorough, we want to do a thorough examination. So maybe this one was a trick question. We want to look at everything regardless. All right, so this is part of the physical exam. I'm going to let you guys do the math. Here's one of your attendings over here taking a look at this patient. What are we seeing on this patient's legs? We see an up close picture in the upper right hand corner, and then we see this physician taking a look at the patient's legs. What are we seeing? Dark spots certainly are. Do you guys know what this is called? Petechial rash close. It's a little more than petechial. Close. Angiomas, hemorrhagic rash. You guys are close. So this is called purpura. Oh, perfect. Yeah, right as I said it, somebody just put it in the chat. You're absolutely right. This is purpura. And this looks like to me, perhaps palpable purpura. Obviously palpable you would have to feel, but this is absolutely purpura. And then what are we seeing here in this picture? Let me pull out my handy dandy pointer. What are we seeing here in this image, this netter image here, which are always fantastic? What are we seeing here? We're seeing that we flex the patient's neck and we're seeing them inadvertently flex their legs. So what is this? Do you guys know this sign? I'll be very, very impressed with you if you do. If you don't, that's okay. That's what I'm here for. Exactly. Brzezinski's sign. Good, good. That's exactly what it's called. So what this is indicative of really is meningeal irritation. There's a couple of signs. I'm going to walk you through them tonight. And it's indicative of meningeal irritation. And specifically, we want to sort of rule in or rule out an infection of the meninges. So let me clear my drawings. All right. So I have a image or a video here for you rather. This gives you a very good sign of it. I saw this video and it's sad. Our patient didn't revert back to a baby. They're not Benjamin Button. This is just a very, very good representation of this. So specifically, when I play the video, I'll play it for a couple times for you. But when the patient flexes their neck, or when you flex the patient's neck, rather, watch the patient, specifically this baby, flex their legs as a result. So this is due to meningeal irritation. So let me play this and stop talking, and you guys can take a look. So you can see here they're flexing the neck, and then as a result, you see the baby's legs kind of flex as a result too. I thought this was a great representation of this. So I'll play it one more time for you. It's a very quick one, but all right. And then on this baby too, specifically for babies with this kind of sign, you might want to look at their fontanelle. It might be bulging. These babies might be hypotonic, pretty limp, and pretty lethargic. But our patient is an adult. That's just kind of an aside for those of you who love pediatrics. All right, so let's keep it moving here. All right, so here's our physical exam. So the patient has a fever at 102.3. So they're pretty hot. 102.3, they're tachycardic, and they're hypotensive. They are breathing okay. They're lethargic appearing, and the patient has altered mental status. Her roommate also told us that the patient was putting her keys in the keys and cell phone in the refrigerator, which I think surpasses the idea of a bad roommate. I think she just might be altered at that point. She also has nuchal rigidity, so meaning a little bit of stiffness. In addition to that, she has a positive Brzezinski sign, as we kind of saw before. The patient is tachycardic, but no murmurs, rubs, or gallops. The lungs are clear to auscultation, and without wheezes, rales, or rhonchi. No abdominal tenderness. There's a little bit of edema to the lower extremities, and there's also that palpable purpura that we talked about before to the anterior aspect of the shin. One sign that I kind of glossed over here is this Koenig sign. And that's what this video over here is going to show you. And what you're going to see is when the physician, when the provider goes to try to extend the leg, the patient's going to feel pain or stiffness or rigidity and not be able to extend that knee. And that's what you're going to see in this video here. Okay, so let me play this for you. Let me clear my chicken scratch and we'll play this. So as you can see here, the physician is trying to extend that leg there and is unable to do it. And if you listen to the audio of this, the patient does express a little bit of discomfort with it. And it's a good sign of it as well. But you can see a little bit of stiffness, and this is a pretty young and what would seemingly be a healthy individual. So that patient should certainly, in the absence of injuries, should be able to extend their knee all the way out like that. Okay. So let's keep going here. All right, it wants to play the video again for you. All right, so in terms of the labs, the key is kind of for you, as always, in the upper right-hand corner there. But what we see a little bit of hyponatremia, and you guys should be masters in hyponatremia. I feel like every case I give you, the patient is hyponatremic, and I know that Michaela has taught you about hyponatremia as well. But other than that, the PT and PTT for clotting is prolonged. And these are measurements of the intrinsic and extrinsic coagulation pathways. And then also the fibrinogen is low. which can be indicative that something is going on here as well. And then when we see this kind of constellation, a prolonged PT, prolonged PTT, a low fibrinogen, what we want to do is look at the platelets. That's what we're looking at over here, and the platelets are low. So this might tell us that there's a consumptive coagulopathy going on. We see a prolonged PTT and PT with low fibrinogen and low platelets. So we know that our clotting factors may be consumed somewhere. Other than this, we see an elevated white count. This is a pretty high white count. So this might point us in the direction of infection. Other than this, at this point, what do we want? What additional testing do we want at this point? You guys tell me, what are we ordering at this point? We got some basic labs. We see a little bit of stuff going on right now. What are we ordering next? What do we want to take a look at? CT or MRI, good idea. I'll take it. CSF. In terms of CSF, good, yeah, lumbar puncture. Exactly. What do we want to do with the lumbar puncture? What do we want to send it for? Are we going to hand it to the lab and say, do tests? What do we want to test? What do we want to know? You guys are on the right track. I'm just, I'm pushing you hard. You guys are a smart bunch. Check for lymphocytes. Exactly. We want to get a cell count. Exactly. We want to get a culture of it. Perfect. You guys are right on track. Good. And we might want to get chemistries on the CSF as well to look for glucose. And things of that nature as well. So good job. You guys are very smart. You guys are maybe scribes. You're very, or nurses are already in the medical field. You're very wise. All right, let's keep it moving here. So somebody told me they wanted a CT. So here's your CT. Now you tell me, you're your own radiologist at this point. Is this normal or abnormal? Pull out your pointer again and let me know, abnormal or normal. Let's give a sort of a pull without the actual pull here. All right, so we have a few votes for normal, a few votes for abnormal. Someone's getting real creative with our lines. And Hope is like the Zoom master. She put her name in her arrow. She's great. But for those of you that said normal, somebody tell me why. You can unmute yourself, let me know, or if you're a fast typer, if you were a scribe, type it fast in the chat and let me know why. Why do you think that this is a normal CT scan? All right, so for those of you that kind of shot an arrow in the dark there and guessed that this was normal, that's okay. Radiology is certainly, some of the images can be difficult to read. So we can go through it together. This is a normal CT scan, so good job for those of you that said it. For those of you that said abnormal, listen here for why this is normal. So we're looking at the CT, and what we see on the scan is bone shows up a little bit lighter in color. So that's what we see here. We see the contours of the skull here in bright white. Air is going to show up black, okay? So bone is white, tissue is gray, and air is black. That's kind of our general rules. And this is kind of a slice through the brain as if we're looking from the top down or the bottom up, depending how we're looking. Okay, so what we're looking at here are are part of the ventricles, and the reason why this is normal is we see sort of good contour of the ventricles here. If we were to see increased intracranial pressure, for instance, we might see what we call slit-like ventricles. So maybe they might be a little bit smaller and kind of compacted. We might see the brain kind of pushed out more towards the skull. And then, of note, in a CT scan of those of whom have neurodegenerative disorders like Parkinson's or Alzheimer's, sometimes we see that the brain is atrophied, but also we see a little bit of brain atrophy in those of whom are aged or older as well, which makes them at increased risk of brain bleeding, subdural hematomas, epidural hematomas, some things like that can cause brain hemorrhages. So that's kind of a side note, but this is an abnormal CT scan. So good job for everybody who answered there. All right, so you guys said you wanted a lumbar puncture. And of note, kind of to go back to this, do any of you guys know why we want to get that the CT scan before we get the lumbar puncture? This is critical. If you guys learned anything from the lesson tonight, this is what I want you to learn. Structure and function. We have a future osteopath in our hands. In the case the lumbar puncture isn't necessary, sort of, giant invasive needle. You're right on track, Stephanie. That's true. Yes, it's invasive. It's an invasive test. Good job. Yeah. So somebody said to check for intracranial pressure. You're absolutely right. What we want to do is introducing a needle is very invasive. And what we want to do is check for intracranial pressure. If there's increased intracranial pressure in the way of a brain abscess, bleeding, in the way of tumors, anything like that, that's going to increase the intracranial pressure and correspondingly have the brain herniate into the spinal cord, which can cause imminent death. And so that is incredibly important to remember. And if there are signs of increased intracranial pressure in the way of papilledema, increased intraocular pressure, altered mental status, which is what our patient had, then we want to get a CT to rule out increased intracranial pressure to make sure we don't cause a herniation by introducing a needle and having negative pressure that's going to allow the brain to herniate. Okay, that's really important. So always remember that that's what we want to prevent doing. We want to prevent harming our patients, obviously. All right, so back to this slide. We sent it to the lab. This is what the lab saw underneath the microscope. So somebody of whom is wise out there, tell me, what are we seeing here? Let's start here with my pointer. What are these two guys next to each other? So we have a vote for lymphocyte and blood cells. Blood cells is right. Rachel, you're very close. It is a white blood cell, Brandon, perfect. And we call these neutrophils. We call them PMNs for short. That's polymorphonuclear. The reason why we see these is to sort of protect against infection. And so when we see an increase in neutrophils, that tells us that there's an acute infection. Neutrophils are the first on the scene. They're the sort of first responders to the infection. And also, Rachel, you are correct. There are lymphocytes here. This is not a great stain. Sort of generally, the neutrophils aren't staining super great, I don't think. But at any rate, there's what looks like a neutrophil here, or I'm sorry, a lymphocyte there and a lymphocyte here. So there are neutrophils there, Rachel. So you weren't wrong. They are definitely there. And both lymphocytes and neutrophils are white blood cells. So everybody who technically answered is correct. And then one more question for you. What are these dots here? What are we seeing here? Any ideas in terms of this? What are we looking at there? Some microbe. That's right. So do we know granules? Close. So what we're looking at is bacteria. We're seeing bacteria on this slide, which, you know, points us in the direction because we knew that this patient is sick. We knew that they had a fever. We know that they have a problem with their coagulation. We know that they have an elevated white blood cell count, also known as leukocytosis. So this is kind of point us in the right direction. So what we're seeing here is gram-negative diplococci. And when we talk about diplococci, and when we say gram-negative, that means they're kind of these pink structures, and they are diplo, meaning two, and they're kind of together like this. So they're gram-negative, and then if we saw purple ones together, those would be called gram-positive. And I have a slide to explain this next, so this isn't so confusing. But if we saw purple ones together, that would indicate to us that perhaps that's a different organism. And that's one of the ways we classify bacteria is by their ability to take up stain. So let me go on to the next slide to explain this a little bit further for you. So this is exactly what I was talking about. So when we stain something in the lab, the bacteria have a cell wall. So those of you that have taken microbiology, it'll certainly help you in school. If you haven't, that's okay too. I'm going to walk you through it here. If you were sleeping in your microbiology class, then maybe pay attention here as well. But on the left, these are two different images. We're seeing an actual image on the top of stained bacteria, and then we're seeing this cartoon of what the cell wall looks like. So when we look at gram-positive bacteria, what we see is a greater thickness of the cell wall. And that is peptidoglycan. That's what takes up the stain. And then in gram-negative bacteria, we see a smaller portion of that peptidoglycan. And so when we use a counter stain to wash off the stain, the crystal violet, the purple stain, will correspondingly go away. And that's why we see pink bacteria, because of that small cell wall, that small peptidoglycan layer. So I hope that makes a little more sense to you. And what we're seeing is we were seeing gram-negative, so this is what we're seeing, gram-negative bacteria, and we were kind of seeing them like this. So we were seeing them together, and we call this diplococci, okay? Cocci meaning they're round, diplo meaning two, okay? So I hope that makes a little more sense, and let's go on here. So we have a good idea really of what we're looking at, hopefully. We have a CT that tells us the CT was normal. We did a lumbar puncture of which told us that we have a lot of white blood cells and a lot of bacteria there as well. Okay, so what else? Anything else? What do we do now? What other tests do we do, if anything? What do you guys say? Are we ready to make a diagnosis, or do we need more tests? Need to figure out what kind of bacteria. That's absolutely right. And when we did the lumbar puncture, as we kind of indicated before, what we're going to do is we're going to send 4 vials, okay? We're going to send 1 for the cell count. We're going to send 1 for culture to microbiology. We're going to send an extra, and then we're going to send 1 for chemistries as well to look at glucose and everything. Okay, so we will figure out the species or the type of bacteria. We'll figure out what type of bacteria we're looking at. And that's predominantly through culture. So we put it on a Petri dish our dish basically, and then we look at based on our biochemical tests and how it grows on the plate. That's how we identify what bacteria it is. Okay. But other than that, what other tests do we need? Anything? TB test. So TB can certainly be a cause of a CNS infection, though. The problem with a TB test, if we do a skin test, is it won't tell us, a lot in the way of if they have an active infection or if they've been exposed. So we might need to do a more specific test in that regard. But what do we want to look at in terms of the blood? What will tell us? What about something viral? Yeah, if we have an indication that something viral is going on, we can do serologic tests. But due to the fact that we saw bacteria in the CSF, the central, the spinal fluid, that tells us that, we're looking at something perhaps bacterial, less likely viral. Okay, so because I haven't gotten the answer that I'm looking for, here you go. What we want to do is we want to get blood cultures. I know you guys know this, perhaps just didn't think of it. So what we want to do is we want to get 2 sets of blood cultures. This is important. We want to get 2 sets of blood cultures from 2 different sites. And when we say 2 sets, what we mean by a set is we want to get an aerobic bottle and an anaerobic bottle. So aerobic meaning it's exposed to oxygen, it grows in oxygen, and anaerobic meaning it does not like oxygen. Okay, so that's what we mean. We want 2 sets, and then two bottles come in each set. Okay, and that's there's a picture here to the right that indicates that the purple one is the anaerobic set, and then the blue one is the aerobic set. Okay, and that's important because just because we saw what the bacteria looks like doesn't mean that we know the oxygen requirement of the bacteria. And as I kind of indicated before, we use the biochemical tests, depending on what tests, how it grows on the agar, and then its oxygen requirements to determine what bacteria we're looking at, which is important because then we can pinpoint what type of antibiotics we want to treat this patient with, because believe it or not, not all antibiotics work against all bacteria. Also, some bacteria of which have been treated sort of historically with certain antibiotics in the past can and have grown to be resistant to those antibiotics. So it's important that we pinpoint what type of bacteria we're looking at. Okay, so what differential diagnosis are we looking at this point? What ideas do you guys have? What are we thinking here that what do we want to put as our #1 diagnosis? What are we looking at? Meningitis. Great job, Brandon. You're absolutely right. I agree with Brandon. I think it is meningitis. We are looking at meningitis. I agree with Brandon. I also wrote the presentation, so that is also why I agree with Brandon. But yes, I think we are looking at a meningitis here. Brandon or anybody else out there, why do you think this is a meningitis? What have we heard from the presentation of the patient that tells us that this might be meningitis? It is scary. You're absolutely right. Gonococcal meningitis. Nice. You're absolutely right. I hope you don't have access to the slides, then you would absolutely know. But yes, this is good. We saw a headache, we saw nuchal rigidity, and then we saw fever. We saw altered mental status. You guys are absolutely right. And with our kind of differential diagnosis of meningitis, we want to say this is probably bacterial. I did list viral to get you guys to think about it, but this is far less likely given the clinical picture that we're seeing. So And then we do want to put tuberculosis because that can be a cause of meningitis, but it's less likely in this patient. And then we can also consider fungal as well, okay? And then in terms of fungal, we want to consider Cryptococcus neoformans. That is what we see here, kind of these circles right here. What we're stating here is something called the India ink stain. And we see this infection with patients of whom are immunocompromised. When the T cell count drops, these are called opportunistic infections that kind of wouldn't affect people of whom are healthy, basically. So the other thing we can consider is parasitic. Parasitic infections, one that we're looking at here, let me advance my my pointer here to show you these two. But one that we're looking at here is neurocysticercosis. That's from the organism Taenia solium. So that is primarily from undercooked pork. And what we see here is this parasite kind of manifesting in the brain, which can cause meningitis. The other one is Toxoplasma gondii, and then we kind of see these encased cystic structures in the brain. We want to worry about that in immunocompromised people. We want to worry about that in pregnant women, primarily in pregnant women because it can cause congenital birth defects, which is very, very serious. All right. It could come from cat litter. Nice, Rachel. You paid attention in your microbiology class. You're absolutely right. It does come from cat litter. And Rachel might have just scored everybody a point on the quiz that you're about to do. So keep an eye out for that. That's kind of foreshadowing for the future. It does come from cat litter. So we tell pregnant moms, if you have a cat at home, tell your significant other to change the cat litter. To take upon that chore for the duration of the pregnancy, at least for the first trimester, to avoid congenital birth defects. Nice, Rachel. You're absolutely right. All right. The other thing we want to include is encephalitis, so sort of infection of the encasing of the brain. We want to consider masses. It's less likely, obviously, given that we had a negative CT. And then we want to consider it in the way of brain tumors, brain abscesses. And then as I kind of indicated, that's less likely because we had a negative CT. All right, so what do we want to do for this patient at this point? What do you guys think? What should be sort of on our plan right now? So we know that our differential includes meningitis, but what do we do? Antibiotics. Nice. Good job, guys. You guys are absolutely right. We have a bacterial infection. We need to treat this patient with antibiotics. Good job. So this is likely bacterial. And given the kind of clinical picture, this is likely Neisseria meningitidis. That's what we see with those gram-negative diplococci. And of note, we commonly see that palpable purpura in young individuals with this infection. So this is what my terrible drawing here is the gram-negative diplococci. That's what we kind of saw in the CSF. We saw that increased white blood cell count, and we saw a consumptive coagulopathy, perhaps indicative of DIC, disseminated coagulation basically in the body. All right, guys, so antibiotics that we want to give, I'm not going to hound you guys on that. These are certainly hard. But two that we want to give is ceftriaxone and vancomycin. So ceftriaxone kind of has a little bit of coverage in terms of gram-positive organisms, also a little bit of gram-negative. And then also vancomycin covers staph. So That's what we typically give for meningitis. If there is an indication that the patient has an infection with an organism known as Listeria monocytogenes, that's an infection also sort of associated with immunocompromised individuals, or if they're pregnant, we want to also give them another drug, which is ampicillin. We want to give them that drug for if we're sort of suspecting an infection, meningitis infection with Listeria. One more thing that we want to consider due to inflammation, we want to consider giving them dexamethasone. We want to give that before or during, concurrently with the antibiotic treatment. There has been studies that show that this sort of helps in the prognosis of patients with meningitis. So that's usually kind of our combination for meningitis, okay? Then, well, this also prevents neurological complications as well. All right, so the next thing that we want to consider is, as we kind of alluded to before, is disseminated intravascular coagulation. So does anybody know the treatment for DIC, disseminated intravascular coagulation? Don't think too hard. I know you guys know the answer. The fibrinogen is low, the clotting factors are being consumed, and the platelets are low. So what do you guys think? What should we give this patient? We can consider giving anti-clotting like heparin if it's a sort of slowly evolving DIC. But if it's DIC, usually what we want to do is replace what's being consumed, so that the patient does not bleed. So what we can do is give platelets. Platelets are low. Let's give platelets. And then if fibrinogen is low, let's give cryoprecipitate. If clotting factors are low, let's give fresh frozen plasma. So you guys are right along that line. So transfusion, good. Yeah, Jonathan, you're absolutely right. You're going to touch on the next point that I'm going to talk about for hyponatremia, which is, this is likely a euvolemic hyponatremia, given that the patient doesn't appear to be dehydrated or increase volume up. They don't look volume down, they look euvolemic likely. So this is a euvolemic hyponatremia. And what we can do is give isotonic fluids. Does anybody have any ideas from your hyponatremia lecture that Michaela gave? What do we want to give for hyponatremia? Do you guys remember what isotonic solutions are available at your disposal to give somebody that has hyponatremia? Yeah, so we want to give normal saline, which is sodium chloride. There's one more. The surgeons love it. Do you guys know what that one is? Yeah, so it's so LR, so it's lactated ringers, or ringers lactate, depending on which way you say it. But lactated ringers, surgeons love it, and that's also a isotonic solution as well. So good job, guys. Yeah, you can also have them stop drinking water. That's absolutely right. Yeah, if they're hyponatremic and they're euvolemic, yeah, you can also stop the water consumption or ingestion. But good point with that. That's absolutely right. And then what we want to do is monitor for resolution of symptoms. We can also follow up on the culture of the CSF and see what grows and make sure we have the right antibiotics, the right organism. Okay. All right, guys. So we're going to start talking about the pathology here in the last few minutes. So there's a few causes of meningitis, and that's primarily what we're focusing on here, if you haven't got that impression already. There's lots of causes of CNS infections. I think meningitis is one of the most important. It's also one of the most interesting, inadvertently. So here we see the few different types. We've kind of touched on them so far. But what we haven't talked about is this idea of how do we kind of pinpoint from the CSF, whether it's bacterial, whether it's viral, whether it's fungal. So as we kind of saw, we have bacterial, viral, and fungal. So this is the one that we're looking at today. We're looking at Neisseria meningitidis. We see that palpable purpura. So I'll add that here to sort of jog your memory. Other ones that we can see is strep pneumoniae. That also is the most common cause of things like pneumonia and ear infections. In neonates and also in older adults and immunocompromised patients, as well as pregnant patients, we want to think of Listeria monocytogenes. For pregnant women, we want to tell them to avoid unpasteurized dairy products. I always remembered my professor in school saying, tell them to avoid queso fresco. So I don't know if there's any queso fresco fans out there, but apparently you're supposed to avoid queso fresco whenever you're pregnant to avoid an infection like this. It's also in deli meats as well, like hot dogs and things like that. But that's neither here nor there. Also, we want to look at group B strep, E. coli, and Haemophilus influenzae, which can be prevented in neonates through vaccination, the HIB vaccination when they're young. Other causes, we see herpes simplex. Somebody mentioned that before, which is a great thing to have on your differential diagnosis for meningitis, so well done. Other causes, influenza, measles and mumps, which are and varicella zoster, those are all prevented through vaccination as well. And then other things, coccidioides, this is in the Southwest. We like to think of that in the San Joaquin River Valley, and then histoplasma and blastomyces. Those are a little more Eastern and Mississippi River Valley. Then there's crypto, and then also Candida as well. But the way we like to kind of look at this basically is through the CSF. And the way we like to think of it is a few things. And I want to highlight those things and not harp on all these little details in this chart. But for bacterial, and as we kind of saw today, what we see is a normal to decreased glucose. And so that's why I said we send that the CSF to chemistry as well, so that they can look at the glucose. The way that I always like to remember that is the bacteria like to eat the glucose, which helps you remember it, but isn't entirely true, because primarily pathophysiologically, what we see is that the bacteria is actually inhibiting the sort of transport of glucose. So it's a little more than bacteria eating glucose. Other than that, we see an elevated white blood cell count, and we see that predominance of neutrophils. Remember that? We saw the CSF, we saw a lot of neutrophils. Then to kind of contrast this with viral, and that's usually the most common. We see bacterial most commonly and viral. Fungal and tuberculosis is a little less common, but we want to include those on our differential. To kind of contrast viral with bacterial, what we see is a predominance of lymphocytes. So there were a few lymphocytes on our slide, but not a predominance of them. And then in comparison, the white count is usually not super elevated like in bacterial. And then we see a normal glucose there. And then for time's sake, we'll kind of skip over the other two as they're less common usually. And then risk factors that we want to include or to consider are extremes of age. So very, very young babies, neonates, premature babies. And then we also want to consider lack of immunizations. If somebody comes in and says they're not immunized and then they have stiff neck, we might consider some of these things that may not get somebody sick otherwise because they're immunized, like Haemophilus influenza type B. Measles, mumps, and rubella. We want to consider those because those are two things that we commonly vaccinate for. The other thing is immunocompromised status. So HIV and AIDS, diabetics, those of whom are abused substances like alcoholics. And then the other things are living in group settings. So college dormitories or assisted living homes or nursing homes, because they're kind of in one area. And then also pregnancy, as I kind of talked a little bit about before. Okay, now a lot of these things we've seen already, which is kind of nice. So we can kind of breeze through this. So we see that Brzezinski sign, we see Kernig sign, we also see nuchal rigidity. And that's all telling us that there's a lot of inflammation of the meninges. We also see purpura and petechiae. Usually tells us that we're looking at Neisseria meningitidis. Remember that petechiae are kind of pinpoint, and then purpura is kind of a little bit bigger, usually palpable, and pretty evident, and kind of points us in the direction of a Neisseria infection, especially if they're kind of young and otherwise healthy. Other than this, we see sometimes altered mental status. We see stupor or coma. In infants, as I kind of talked a little bit about, you can kind of see, we can see hypotonia, so decreased tone, lethargy, a bulging fontanelle. Obviously, I don't have one, mine is closed. But in babies, you can see it, the kind of skin poking out because there's increased intracranial pressure there due to the infection. You can see kind of irritability and fever in babies as well. Okay, and then labs, we want to consider CBC, CMP. That can kind of point us in the direction if there's an increased white blood cell count. CMP might tell us if there's a problem with the electrolytes. We want to look at blood cultures, and then also we want to get a lumbar puncture, but not until we've ruled out with a CT increased intracranial pressure that could cause herniation. Okay, so all these things are things that we talked about before, so that should be hopefully a good review for you. And then also we kind of see here a little bit of the anatomy here. So what we commonly do is we pinpoint the L3, L4 vertebra, and that's what this is showing. And you guys will have access to my slides, so I'll leave this video for you to watch for the sake of time, because I do have a few questions that I want you guys to go through to practice, as always. And this is a very good video. It's I plan to kind of narrate it, but the narrator does a very good job anyway, so you guys can certainly watch that. But what we want to do is kind of pinpoint the L3 to L4 vertebra. And the way we kind of know that we're at the L4 vertebra is due to the iliac crest. So which are essentially the hip bone. So we go up, we march up to the iliac crest, and then what we see is when we go over sort of at the same level as the iliac crest is the L4 vertebra. And that's how we can kind of tell from the spinous processes of the vertebra that we're at L3, L4. We're going to kind of mark the site as kind of shown in this video. And then here, what we're seeing, I'll kind of show you here, is the physician kind of placing the needle in. And what we see is after the physician has removed the stylet, we see the spinal fluid kind of dropping into the vials. And obviously before this, we're going to sort of prep the patient in terms of anesthetic. We want to numb it. This is a very painful procedure. And then also clean the area as well. Okay, but that's kind of a quick version of that, but you guys will have access to my slides and be able to kind of watch this in depth. It's a short video, it's 10 minutes. If you're like me and you put it on 2x speed, then it's 5 minutes. All right, so let's see. In terms of complications of meningitis, we want to consider neurological deficits. We want to consider loss of hearing, memory loss, difficulty learning, seizures, and coma. Other than that, we want to think about brain damage, so problems with gait, shock as a result of the infection itself, organ failure, and death. Okay. All right, so as promised, here's a few questions for you all. Let me start the poll. Sorry, wrong one. Let me launch this one. So this is a 22-year-old male presenting to the ED with neck stiffness. The patient notes that he goes to the local university and lives in a college dormitory. CT scan was unremarkable. The LP shows the following. So I'll give you guys a few seconds here. I want the vast majority of people to kind of answer the poll here. And there's 3 of these today, so they should go fairly quickly. And we're nearly to the end, so hang with me a few more minutes. And if you guys have to go, I definitely understand that as well. So there's a few more of you out there. I want to give everybody the chance to kind of vote and sort of apply what you've learned here. All right. Let me share that with you guys. So great job, guys. The vast majority of you, 59% of you, said that this is bacterial meningitis. Great job. So this is an LP. So by sort of process of elimination, we can eliminate nuchal rigidity. That's a physical exam finding, not an LP finding. Same thing with Brudzinski sign and Rovsing sign, as well as palpable purpura. So it really narrows us down to 3 other things. Okay, so for those of you that answered palpable purpura, that's more of a physical exam finding on the skin. Okay, and then on the LP, we kind of see we see bacteria very sort of similar to what we saw. Also, this arrow is very kind, or this image was very kind to point out to you what you should be looking at. And you gotta love when images do that. So in case you don't see their arrows, there's my blue arrow pointing to bacteria on the slide. Okay, so let's keep it moving here. All right. So next question here. Same kind of STEM, but this is a 23-year-old male presenting to the ED with neck stiffness. Same thing. This guy lives in a college dorm, and CT scan was unremarkable. LP shows the following. So what are we looking at now? So remember here, there are what we see are lymphocytes. So remember, if we are looking at neutrophils, what we're going to see is kind of the sort of this is kind of what segmented neutrophils. We kind of see the segmented nucleus. That's what a neutrophil looks like, which tells us that is bacterial. So I'll put a B here for bacterial. And here what we're seeing is lymphocytes. So we see that nucleus of the lymphocyte, it's all kind of one nucleus all together. That's what we see here. So we see a predominance of neutrophil, or I'm sorry, lymphocytes. I don't want to confuse you guys. So we see a predominance of lymphocytes, which tells us that this is one particular type of infection, okay? So what we see, the vast majority of you guys, great job, said viral. When we see a predominance of lymphocytes, we want to think viral. If we saw a predominance of segmented neutrophils, then we would want to think bacterial, okay? So Final question for you guys, okay? So same kind of answer choices, but let me relaunch this and let me play this video for you. This is a 3-week-old baby presenting with hypotonia and lethargy. On examination, you see this. So we see that when we flex the head, we see also flexion of the legs. So what is that called? Do you guys remember? You guys are doing great. All right, so you guys all got it. And in case you missed the title that showed on the video, which I can never get rid of, this is Brudzinski's sign, which is when we flex the neck, we see the flexion of the legs as well due to the meningeal irritation. Remember that Koenig's sign, Rovsing's sign is a different sign associated with the abdomen. So if you remember back then, when you press on the abdomen on one side, it elicits tenderness on the other side. So Koenig actually wasn't listed here. So, but Koenig's sign is whenever you try to extend the leg, you kind of get this resistance or pain with extension or prevention of extension of the leg. Okay, remember Rovsing from the abdomen lectures. Okay, all right. So this is the last slide, and basically, and this should read meningitis up here. But for meningitis, what we want to do, we want to obviously, in terms of the treatment, we want to sort of narrow in on the antibiotics. Obviously, we can start with the ceftriaxone, vancomycin, and dexamethasone. That's sort of what we do empirically, and then we can send it for culture and kind of make sure that that's the bacteria that we're treating can be covered by the antibiotic. We can also give dexamethasone, the steroid, to prevent neurological complications, reduce inflammation. And then if we do get a culture on the CSF from the lab that indicates that it's something else, then we can change our antibiotic. So it's a little bit less, this complicated, obviously, flow chart gets a little more simple when we kind of think it out. But I have one more poll for you guys, if you would be so kind to answer the last poll. Let me relaunch this for you, and let's see where you guys are at now after the sort of a little over an hour. All right, so let me share this with you guys as to not take up too much more of your time. So I'm very honored. Most of you guys got out of the I know nothing category, which I'm very glad. Some of you guys said you know a little. That's okay too. It's a very complicated topic. 2 more of you people said you know a lot. I'm very honored. It was an honor to share the last hour or so with you guys. I always enjoy doing this. This is one of my passions. And one of my favorite parts of my week when I can spend it with you guys. So what's next? There's the quiz out there for you, 10-question quiz. You should be able to get that on the first attempt. Hopefully, that's my goal for you guys. then you'll get that certificate of completion so that you can write that in your applications to come. Next week, we're doing another presentation. So come back next week, tell your guys' friends. We hope that this is helpful for you guys. I'll stick around for the next few minutes if you guys have any questions. Thank you guys for your time. I appreciate you guys. I appreciate your guys' participation. It's always a pleasure. So I'll stick around for the next few minutes if any of you guys have any questions for me. So good question. The presentation of encephalitis would be very similar. It kind of presents in the same way in terms of maybe a little more altered mental status, you know, maybe a little bit less in the way of pinpointed physical exam findings. It can be a little bit obscure in that regard as well. So it is kind of hard to delineate in terms of that. Realistically, we can kind of treat with similar antibiotics. So at a certain point, encephalitis, infection of the surrounding of the brain, perhaps wouldn't be in the meninges. So we wouldn't see perhaps sort of the same findings in the CSF as well. So yes, absolutely, Jalen, we can go through that. So the subjective is primarily the things that the patient tells us. So that's like the HPI and the ROS. So the things that the patient is telling us is going on. The objective is going to be things that we find, for instance, the vital signs, the physical exam findings, and then assessment, that's going to be kind of our differential diagnoses. And so when we talked about encephalitis, when we talked about meningitis, when we talked about brain abscesses, and we kind of laid out that assessment in our differential diagnosis, including DIC and hyponatremia. We want to put all of that on our assessment. And then plan is what we're going to do to address those things, what we're going to do to address the meningitis, what we're going to do to address DIC, and what we're going to do to address the hyponatremia. So hopefully that's a little more clear for you. Don't be sorry, that's a great question. A lot of people don't learn how to write SOAP notes until they get into medical school.